Trichotillomania is an impulse control disorder characterized by the compulsive urge to pull out one's hair, which leads to hair loss, balding and distress, and often social or functional impairment. It appears in the ICD Chapter 5 on mental and behavioral disorders, and is often chronic and difficult to treat. Trichotillomania may be present in infants, but the peak age of onset is 9 to 13. It may be triggered by depression or stress, owing to social implications. The disorder is often unreported and it is difficult to accurately predict its prevalence. The lifetime prevalence is estimated to be between 0.6% and 4.0% of the overall population. Common areas for hair to be pulled out are the scalp, eyelashes, eyebrows, legs, arms, hands, nose and the pubic areas. The name coined by French dermatologist François-Henri Halipeau derives from the Greek theta rho iota chi, tau rho iota ithrix, trick, tau iota lambda lambda epsilon iota nuclein, and mu alpha nu iota alpha mania. Classification. Trichotillomania is defined as a self-induced and recurrent loss of hair. It includes the criterion of an increasing sense of tension before pulling the hair and gratification or relief when pulling the hair. However, some people with trichotillomania do not endorse the inclusion of rising tension and subsequent pleasure, gratification, or relief as part of the criteria, because many individuals with trichotillomania may not realize they are pulling the hair. Patients presenting for diagnosis may deny the criteria for tension prior to hair pulling or a sense of gratification after hair is pulled. Trichotillomania may lie on the obsessive-compulsive spectrum, also encompassing obsessive-compulsive disorder, body dysmorphic disorder, nail-biting and skin-picking, tic disorders and eating disorders. These conditions may share clinical features, genetic contributions, and possibly treatment response. However, differences between trichotillomania and OCD are present in symptoms, neural function and cognitive profile, in the sense that it is associated with irresistible urges to perform unwanted repetitive behavior. Trichotillomania is akin to some of these conditions, and rates of trichotillomania among relatives of OCD patients is higher than expected by chance. However, differences between the disorder and OCD have been noted, including differing peak ages at onset, rates of comorbidity, gender differences, and neural dysfunction and cognitive profile. When it occurs in early childhood, it can be regarded as a distinct clinical entity, because trichotillomania can be present in multiple age groups. It is helpful in terms of prognosis and treatment to approach three distinct subgroups by age: preschool-age children, pre-adolescents to young adults, and adults. Trichotillomania is often not a focused act, but rather hair pulling occurs in their trance-like state. Hence, trichotillomania is subdivided into automatic versus focused hair pulling. Children are more often in the automatic or unconscious subtype and may not consciously remember pulling the hair. Other individuals may have focused or conscious rituals associated with hair pulling, including seeking specific types of hairs to pull, pulling until the hair feels just right, or pulling in response to a specific sensation. Knowledge of the subtype is helpful in determining treatment strategies. Signs and symptoms. Trichotillomania is usually confined to one or two sites, but can involve multiple sites. The scalp is the most common pulling site, followed by the eyebrows, eyelashes, face, arms, and legs. Some less common areas include the pubic area, underarms, beard, and chest. The classic presentation is the friar tuck, a form of vertex and crown alopecia. Children are less likely to pull from areas other than the scalp. People who suffer from trichotillomania often pull only one hair at a time, and these hair-pulling episodes can last 4 hours at a time. Trichotillomania can go into remission-like states where the individual may not experience the urge to pull for days, weeks, months, and even years. Individuals with trichotillomania exhibit hair of differing lengths. Some are broken hairs with blunt ends, some new growth with tapered ends, some broken mid-shaft, or some uneven stubble. Scaling on the scalp is not present. Overall hair density is normal, and a hair pull test is negative. Hair is often pulled out, leaving an unusual shape. Individuals with trichotillomania may be secretive or shameful of the hair-pulling behavior. An additional psychological effect can be low self-esteem, often associated with being shunned by peers and the fear of socializing. Due to appearance and negative attention they may receive. Some people with trichotillomania wear hats, wigs, false eyelashes, eyebrow pencil, or style the hair in an effort to avoid such attention. There seems to be a strong stress-related component. In low-stress environments, some exhibit no symptoms whatsoever. This pulling often resumes upon leaving this environment. Some individuals with trichotillomania may feel they are the only person with this problem due to low rates of reporting. For some people, trichotillomania is a mild problem, merely a frustration. But for many, shame and embarrassment about hair pulling causes painful isolation and results in a great deal of emotional distress, placing them at risk for a co-occurring psychiatric disorder, such as a mood or anxiety disorder. Hair pulling can lead to great tension and strained relationships with family members and friends. Family members may need professional help in coping with this problem. Other medical complications include infection, permanent loss of hair, repetitive stress injury, carpal tunnel syndrome, and gastrointestinal obstruction as a result of trichophagia. In trichophagia, people with trichotillomania also ingest the hair that they pull. In extreme cases, this can lead to a hairball, Rapunzel syndrome, an extreme form of trichobezoar in which the tail of the hairball extends into the intestines, can be fatal if misdiagnosed. Environment is a large factor which affects hair pulling. Sedentary activities such as being in a relaxed environment are conducive to hair pulling. A common example of a sedentary activity promoting hair pulling is lying in a bed while trying to rest or fall asleep. An extreme example of automatic trichotillomania is found when some patients have been observed to pull the hair out while asleep. This is called sleep-isolated trichotillomania. Causes and pathophysiology. Anxiety, depression and obsessive-compulsive disorder are more frequently encountered in people with trichotillomania. Trichotillomania has a high overlap with post-traumatic stress disorder, and some cases of trichotillomania may be triggered by stress. Another school of thought emphasizes hair pulling as addictive and negatively reinforcing, as it is associated with rising tension beforehand and relief afterward. A neurocognitive model, the notion that the basal ganglia plays a role in habit formation and that the frontal lobes are critical for normally suppressing or inhibiting such habits, sees trichotillomania as a habit disorder. Abnormalities in the caudate nucleus are noted in OCD, but there is no evidence to support that these abnormalities can also be linked to trichotillomania. One study has shown that individuals with trichotillomania have decreased cerebellar volume. These findings suggest some differences between OCD and trichotillomania. There is a lack of structural MRI studies on trichotillomania. In several MRI studies that have been conducted, it has been found that people with trichotillomania have more gray matter in the brains than those who do not suffer from the disorder. It is likely that multiple genes confer vulnerability to trichotillomania. One study identified mutations in the SLITRK1 gene. Another identified differences changes in the serotonin 2A receptor genes, and mice with a mutation on the HOXB8 gene showed abnormal behaviors including hair pulling. These data are preliminary, but could indicate a genetic component in trichotillomania. The more research that surrounds this relatively newly understood phenomenon, the closer that experts come to determining whether or not it is indeed gene-linked. According to Mario Capecci, mutating microglia cells of mice resulted in a pathology that was similar to the human condition of trichotillomania. Transplanting normal bone marrow into mutant mice permanently cured them of this pathology. Diagnosis and screening. Patients may be ashamed or actively attempt to disguise the symptoms. This can make diagnosis difficult as symptoms are not always immediately obvious or have been deliberately hidden to avoid disclosure. If the patient admits to hair pulling, diagnosis is not difficult. If patients deny hair pulling, a differential diagnosis must be pursued. The differential diagnosis will include evaluation for alopecia areata, iron deficiency, hypothyroidism, tinea capitis, traction alopecia, alopecia marchinosa, thallium poisoning, and loose allergen syndrome. In trichotillomania, a hair pull test is negative. A biopsy can be performed and may be helpful. It reveals traumatized hair follicles with parafollicular hemorrhage, fragmented hair in the dermis, empty follicles, and deformed hair shafts. Multiple catagen hairs are typically seen. An alternative technique to biopsy, particularly for children, is to shave a part of the involved area and observe for regrowth of normal hairs. Treatment. Treatment is based on a person's age. Most preschool-aged children outgrow the condition if it is managed conservatively. In young adults, establishing the diagnosis and raising awareness of the condition is an important reassurance for the family and patient. Non-pharmacological interventions, including behavior modification programs, may be considered. Referrals to psychologists or psychiatrists may be considered when other interventions fail. When trichotillomania begins in adulthood, it is often associated with other mental disorders, and referral to a psychologist or psychiatrist for evaluation or treatment is considered best. The hair pulling may resolve when other conditions are treated. Psychotherapy habit reversal training has the highest rate of success in treating trichotillomania. HRT has been shown to be a successful adjunct of medication as a way to treat trichotillomania. With HRT, the individual is trained to learn to recognize their impulse to pull and also teach them to redirect this impulse. In comparisons of behavioral versus pharmacologic treatment, cognitive behavioral therapy have shown significant improvement over medication alone. It has also proven effective in treating children. Biofeedback, cognitive behavioral methods, and hypnosis may improve symptoms. Acceptance and commitment therapy is also demonstrating promise in trichotillomania treatment. Medication. In the United States Food and Drug Administration has not approved any medications for trichotillomania treatment. Medications can be used to treat trichotillomania. Treatment with clomipramine, a tricyclic antidepressant, was shown in a small double-blind study to significantly improve symptoms, but results of other studies on clomipramine for treating trichotillomania have been inconsistent. Naltrexone may be a viable treatment. Fluoxetine and other selective serotonin reuptake inhibitors have limited usefulness in treating trichotillomania, and can often have significant side effects. Behavioral therapy has proven more effective when compared to fluoxetine or control groups. Dual treatment may provide an advantage in some cases, but robust evidence from high-quality studies is lacking. Acetylcysteine treatment stemmed from an understanding of glutamate's role in regulation of impulse control. Many medications, depending on individuality, may increase hair pulling. devices. Technology can be used to augment habit reversal training or behavioral therapy. Several mobile apps exist to help log behavior and focus on treatment strategies. More recently, some companies have begun producing wearable devices and smartwatch applications that track the position of users' hands. Sound or vibration notifications can be used to notify users of passive hair pulling, and automated journals can show progress over time. Prognosis. When it occurs in early childhood, the condition is typically self-limiting and intervention is not required. In adults, the onset of trichotillomania may be secondary to underlying psychiatric disturbances, and symptoms are generally more long-term. Secondary infections may occur due to picking and scratching, but other complications are rare. Individuals with trichotillomania often find that support groups are helpful in living with and overcoming the disorder. Epidemiology. Although no broad-based population epidemiologic studies had been conducted as of 2009, the lifetime prevalence of trichotillomania is estimated to be between 0.6% and 4.0% of the overall population. With a 1% prevalence rate, 2.5 million people in the U.S. may have trichotillomania at some time during their lifetimes. Trichotillomania is diagnosed in all age groups. Onset is more common during pre-adolescence and young adulthood, with mean age of onset between 9 and 13 years of age, and a notable peak at 12-13. Among preschool children, the genders are equally represented. There appears to be a female predominance among pre-adolescents to young adults, with between 70% and 93% of patients being female. Among adults, females typically outnumber males by 3 to 1. Automatic pulling occurs in approximately 3/4 of adult patients with trichotillomania. History. Hair pulling was first mentioned by Aristotle in the 4th century BC, was first described in modern literature in 1885, and the term trichotillomania was coined by the French dermatologist François-Henri Halepeau in 1889. In 1987, trichotillomania was recognized in the Diagnostic and Statistical Manual of the American Psychiatric Association, 3rd edition revised. Society and culture. Support groups and internet sites can provide recommended educational material and help persons with trich in maintaining a positive attitude and overcoming the fear of being alone with the disease. Non-profit organizations. The TLC Foundation for Body-Focused Repetitive Behaviors is the only American non-profit dedicated to funding research for a cure. This organization was previously called the Trichotillomania Learning Center, which was founded in 1991 by Christina Pearson. The foundation helps people overcome and heal from body-focused repetitive behaviors in 4 ways. 1. Connect affected individuals and their families with each other, thereby helping to end their isolation and providing a community of support. 2. Refer people to appropriate treatment providers, services, and educational resources so that they can take better control of the recovery. 3. Conduct outreach to healthcare providers and educators, teaching them how to recognize these disorders and train qualified mental health professionals in the latest evidence-based cognitive behavioral treatment approaches. 4. Design and fund research projects aimed at understanding the neurobiology of these disorders and identifying pharmacological and behavioral treatments, as well as possibilities for prevention. Canadian BFRB Support Network is another non-profit organization providing support and educational resources for those in Canada. They have a community of support groups, volunteers and advocates. In the media, a documentary film exploring trichotillomania, Bad Hair Life, was the 2003 winner of the International Health and AMP Medical Media Award for Best Film in Psychiatry and the winner of the 2004 Superfest Film Festival Merit Award. Trichster is a documentary that follows 7 individuals living with trichotillomania, as they navigate the complicated emotions surrounding the disorder, and the effect it has on their daily lives. The film was released digitally on iTunes and VHX on April 18, 2016. The online community Reddit contains a subreddit dedicated to trichotillomania which hosts over 3,700 subscribers. The subreddit, known as r/Trichsters, also refers to its readers as Trichsters. On January 10, 2011, the TLC television show My Strange Addiction showcased Haley, a woman who lives with trichotillomania. A character in the movie The Internship suffers from trichotillomania. He is seen pulling out hair from his right eyebrow during sections of the movie. Mavis Gary, Indiana, of the film Young Adult, suffers from trichotillomania. The mother of the heroine in Gillian Flynn's Sharp Objects suffers from trichotillomania. Rebecca Brown, a YouTuber who goes by the usernames Becky Brown, Trich Journal, and Becky Brownit, actively talks about her experiences with trichotillomania. A short documentary, Hair, featuring a Sikh, African American, and a trichotillomaniac talks about the different views of hair to each individual.